This is what they would and
okay, well, go ahead and start since there'll be people who. Okay, good morning. Today we have two topics in the same session. We're starting off with Darlene Higgins, who is the former manager, retired for several months now, but still very engaged and shared the retention and recruitment shared facility here at UAB, which is one of the shared facilities set up by the Cancer Center. Its primary role is to support subject recruitment and retention for studies in cancer research, but it's really accessible to the whole UAB community. And I hope Ms. Higgins will give you some of the sense of some of the ways you could do that. But she's going to talk more generally about retention and recruitment of subjects in clinical trials. We'll take a short break at 9, and then Penny Jester is going to talk about good clinical practice in the study research and I guess maybe you'll introduce your colleagues.
Okay. Sure. Great. It's great to be here this morning on this chilly morning. We're so happy that the CTSTP has invited us to share our experience with recruiting participants for clinical trials. So as Dr. Chapman said, I retired recently, and my colleagues here, Cynthia Johnson and Julie Shaw, have been working in the facility and are now the co-managers. Cynthia, you joined the facility in 2001, and Julie started working on the National Lung Screening Trial with me in 2002. And so, and all of our staff members are very experienced, but we're happy to be here and talk with you about our facility and recruitment in general. So the recruitment and retention shared facility was established by Dr. Mona Fuad, and at first was a facility for the Division of Preventive Medicine. There were a number of researchers who were doing large population-based studies, and there was a need for help in recruiting. Then in 97, the facility was made a shared facility with the Cancer Center. And since that time, our staff has fluctuated from maybe 10 up to 25 or 30 at one point in some of our large studies. But in since 97, we have recruited 33,000 participants in clinical trials, more than 90 studies. Oh, before I start, how many of you have, I'd like to get a feel for, how many of you have recruited for research studies? So this is an experienced group then. Our team includes coordinators, telephone interviewers, we have data managers and analysts, and we have access to statisticians in the division, and community outreach personnel, patient navigators. And we have recruited for large population-based studies as well as small therapeutic clinical trials. Behavioral intervention, we do telephone surveys, we do focus groups, and one-on-one qualitative interviews. And our expertise is in recruiting minorities and women. And for any investigator that is wanting help on campus, we can be considered a one-stop shop for recruitment services. We will identify and target your population for recruitment. We can consent, enroll, and schedule participants for clinic visits. We have a great data system that can generate data reports to monitor progress in recruitment and to do your IRB reports, as well as any customized reports that an investigator might want in order to track recruitment efforts. And at the end of the recruitment period, we'll provide data extracts in any format that the investigator wants. We, again, have links with data analysts, behaviorists, statisticians, and any other support that you might want in analyzing the data for publications. And we also provide retention services to do follow-up data collection for the same participants that we recruited. These are some of the examples that we, as I said, and one time when I said we recruited 33,000 participants, said, you mean you screened them? I said, no, we enrolled them. So some of our larger studies have been the Women's Health Initiative and 4,000, more than 4,000 participants with 40% African Americans. Two of our largest studies were the prostate, lung, colon, and ovarian cancer screening trial. Whether you've heard of that one. I was the coordinator. Dr. Mona Fuad was the PI on that study, and we enrolled 6,000 people. We followed them for 16 years. And that study just ended a few years ago. The National Lung Screening Trial was another large study that we recruited 5,000 people for. And some of these other studies, those were large population-based recruitment efforts. Impact of religiosity on cancer behaviors was a survey, random digit dialing survey. We enrolled 400 people from across the nation doing telephone interviews. The Deep South Navigation Network just finished this past December. That was a Medicare project where we surveyed, there were 10 centers in Alabama, Georgia, and Tennessee, and we did telephone interviews about patient navigation services, and that we just finished recently. Impact is a project that Dr. Fuad started, increasing minority participants in clinical trials. Many of our studies have been large population-based studies, and it was determined that cancer center investigators really needed some support to recruit for therapeutic clinical trials. And so this project was is funded by the NCI and is looking to increase minorities in clinical trials. When this started in about 2004-05, the percentage of African Americans in clinical trials throughout the cancer center was about 13%. And I wanted to raise it to more represent the catchment area and the population in the clinics and hospitals. And that was accomplished. It was raised to about 18% over the course of this clinical trial. So it is working using patient navigators to serve as a liaison between investigators and to provide support services to provide better access. So those are just some samples. The backbone of one of our services, one of the strengths of our recruitment unit is our data system. And as you may know, many of the software packages that you can purchase off the shelf manage clinical trials from the time of enrollment with follow-up activities. It's very hard to find a recruitment management tool. So this one, our system was custom built by a programmer in our division, and it has several important components, but we have a mass mailing database with 4 million names of individuals, residents of Alabama, and also the Atlanta metro area for one of our big studies in list. we recruited from Atlanta as well as the North Alabama area. We can target populations by race, gender, age, and we have their addresses and some phone numbers, but this is one of our powerful tools for starting a recruitment package. The tracking system, though, is the most unique part, because when we load, say, a mailing data list in, we mail for 10,000 people, then we can track every event after that from that participant. We'll know if they were eligible or ineligible. First of all, whether they responded to the materials we mailed, if they were screened, if they were eligible or not eligible, and then if they were scheduled for appointments, if they enrolled in the study, and all through the clinical trial if the investigator wants us to do that. So this allows us to know exactly what is happening with our recruitment efforts from beginning to end. And we also developed a health profile system that we collected questionnaires of individuals who were interested in participating in research at some point in the future. So we collected about 8 or 10 variables about their status so that we could contact these individuals about potential studies that they might be eligible for. Rather than just dropping mail to the general population, this allowed us to target some specific health conditions. And then the system also supports questionnaires that are study specific and allows us to track the same individual if they've joined more than one study. So it's a very robust data system that gives us a lot of flexibility. So, as you know, startup study is the most difficult time to get everything ready, to get started, and to build your system. And for investigators, successful recruitment is the first step in getting this trial started right. If you don't screen properly, your whole study is in jeopardy. Poorly screened subjects can result in high dropout rates, people that are not eligible that have to be excluded later, and all this affects sample size and power calculations. So it's important to really start right in any recruitment effort, as you know. And our facility can help do that. Our definition of successful recruitment is to reach our recruitment goal on schedule, within budget, and while recruiting participants accurately so that they they're retained in the clinical trial. We have based our strategies and our methods on principles of health behavior, that then we choose the principles or the strategies that are most appropriate for any particular study for that targeted population. And some examples which won't belabor this point because I know you're familiar with them already. The health belief model, social marketing, the Prochaska model of change, and case management theory. But in planning your strategies, often we think we know what a patient might need or might be interested in, but really what matters is what the patient thinks he needs. And that should guide our trying to figure out what the patient is thinking or the potential subject is thinking is important in planning your strategies. So you can't assume that we know what they're thinking. Social marketing uses commercial marketing, proven methods, and we adapt those for behavior change. Anytime you're recruiting a participant for a clinical trial, you're trying to change their behavior. So some of these theories can help you strategize more effectively. Prochaska's model of change is useful in thinking about the way a patient might be thinking. Are they ready to join a stop smoking program or a clinical trial? Going through the stages of change, helping understand where they might be, and tailor your strategies for various levels of change. Case management was very effective, and it has been for many clinical trials in finding out what the participant needs in order to participate. This HIV trial provided some services that enabled people to join the trial more effectively. So we use parts of many of these principles to plan our strategies. So this is just an overview of the recruitment process. First of all, you must identify your audience and where you're going to find them and how you're going to reach them. The strategies that are most commonly used are mass media, radio, television. We use paid ads, which are not as effective. The more effective, if you're going to use print media, we found, is to do interviews with PIs or with participants, do a human interest story. Talk shows on television, all kinds of those approaches. Mass mailing is still one of our most effective tools. I don't know whether you've used mass mailing in your efforts. Anybody? We're used to getting a lot of junk mail, and so it's important to make sure when you use mass mailing that you use it most effectively, because it does cost a lot of money, but it is a way of reaching out, especially to population-based studies or the general public. We've done a lot of community outreach with churches, with workplace organizations, teachers' retirement, word of mouth. Health fairs are sometimes effective, sometimes not so much, but it's a way of getting the message out that there is a research study being done. Physician referrals, being in the medical center, we always assume that we can have easy access to patients, but have you found that to be true? HIPAA protects the privacy of individuals, and physicians are very busy and often will approach a physician saying, we have a study, we think your patients may be interested in diabetes study, for example, and if you could refer some of your patients to us, we really appreciate it. And they'll say, this sounds like a great study, I'd be very interested in it, but I don't have the time. Have you heard that? And my nurses don't have the time either. So reaching the patients that are all around us is the trick. Now, CCTS centers are working to find ways to reach our patient population while protecting their privacy. And this is going to be a great boon to be able to contact patients and finding a way to do it appropriately. Social media, 10 years ago, this was not an issue, but we are catching up. Facebook, websites, email are all useful, very useful tools, especially with the younger population, busy working population. Figuring out how to do that within IRB guidelines and appropriately is the challenge, and but it's a great tool. And then, as I mentioned, the patient navigation program that we've established is another way of reaching patients in their clinics. And of course, the next step is to create your recruitment after you've selected your mode of contact and your materials. Make sure that they fit your targeted audience, and then lastly, you need to track and monitor your recruitment progress very carefully. You can waste a lot of time if you're not knowing exactly where you are, what is working, what is not working, and being able to ramp up or back off depending on if you're scheduling participants in a clinic. All of these measures have to be monitored very carefully to get the most from your staff and to use your population most effectively. So reasons to participate in research studies, these are the common ones, benefits to a person's own self, free clinical exams, often access to healthcare professionals that they may not have had contact with before, access to cutting-edge treatments that are not yet available. Participants are compensated often for their participation, but not always. And this feeling of satisfaction of knowing that a participant is contributing to a larger group and important effort. Altruism is a big motivator for participants, and being able to project what the possible benefits are is extremely important. Many cancer patients are especially concerned with helping others in the future with the same condition, and that's a powerful motivator, and of course helping future generations. So figuring out what are the hooks for your study, what will motivate people to want to be in your study is important before you ever begin. As you design your materials, as you design your approach, what is going to draw people to your clinical trial. And equally important is to understand the barriers to participating. We like to think people will just say, this is a great study, I want to be a part of it. But there are all kinds of barriers. Fear and mistrust are big ones, especially in the African American community after Tuskegee, and also with just experience in their own lives in the medical community. But this is true of many people, though. No one wants to be a guinea pig, and we hear that comment sometimes in recruiting. I don't want to just be a number, and I'm not sure about the study. So one way to overcome that fear and mistrust is to, when you screen a patient, talk with them and conduct a little mini interview to see what their issues are or concerns. And this is a very important part of the process. It's easy just to do a quick screener, but the personal touch we have found is very important. No one wants to be a number. No one wants to be just shuttled through a research study. And if you take the time to make the personal connection and establish a rapport, find out what the patient's motivations are, a little about their situation, what other barriers they might have. Working people have all kinds of demands on their time. Retired people often are caring for grandchildren too. But understanding what their issues are and documenting that in notes and so on, so that your co-workers and staff can know the more information you have about this individual patient, the more likely you can follow up with them appropriately. Socioeconomic barriers can be transportation, low income, language can be a barrier. But you know many of these barriers, but to address them effectively is the goal. Barriers for healthcare providers, as we said earlier, many physicians just don't have time to participate, to recruit for you, or to refer patients even. Other issues are that they may feel uncertain about the study. They don't know the study, what you might be telling their patients. So it's important to establish a relationship, and we found that the most effective way is to be in the clinic, meet the clinic staff, meet the doctor, let them know what your procedures are, establish convenient procedures so that you're not in the way, but that you and don't impede progress, but that you're there when a potential participant may come in. Another issue is sometimes loss of authority. They don't know what we might be telling their patients. Sometimes this is more true on the outside for investigators that are not associated with UAB. We've worked with doctors in other clinics around the city, and sometimes there's an issue of, well, if I refer a participant to your study, what are my responsibilities? Could that come back on me? So, and also many physicians say, I am caring for my patients. I'm not a scientist, that's not my job. And so understanding all these undercurrents can help you address and build a relationship with that staff and build trust. And when we were starting the impact study, increasing minority participation in clinical trials, we had a great bit of difficulty getting into the clinic. They have their routines, they're busy seeing patients, but also doing their own research. And donuts sometimes help. Anything you can do to warm up the staff and help them not be in their way. Then there are barriers related to study design, and you know how long the consent forms are, especially for therapeutic clinical trials, sometimes 25 pages. They are written by lawyers for other lawyers, and they are a real barrier for many patients. And they may be interested in the trial, and they get to the some of those clauses that UAB is not responsible for any injuries, and you have to be able to deal with that. And gain their trust, explain it in common sense terms, involve the family in this process, and provide a lot of time to think about it, to answer questions. And this is one way our navigators have been very helpful, because they're community liaison people, and they may introduce the patient to the clinical trial and say, now, if you after you meet with the doctor, the nurses, call me if you have questions, and she can link that. And sometimes people will, patients will ask the navigators a question if they are maybe hesitant to ask a nurse or a physician. But for the patients to have the time to do that is critical. Randomization is a big barrier. People say, well, I'd like to be in the study, but I want to get the real medicine. I'm not willing to do this for the placebo. So it's important to be able to explain why a randomized controlled clinical trial is important. And taking the time to say, you know, this randomized clinical trials are the best ones. We don't know often what is the best treatment. This medicine looks very promising, but we don't know for sure. Or the dosage. It's important for people to be blind. The doctor doesn't know, you don't know, everyone is blinded. And then you can really track whether this is effective. And to explain the importance of a randomized clinical trial. And if patients understand that, it reassures them. And to reassure them that there are safeguards in place, all the monitoring that's done is for their safety, and to just reassure them. And this takes time, but that's, especially at the first, that's when you're bonding with the patient, trying to gain their trust, and let them know that there's someone that they can ask questions easily and not feel overwhelmed. Time commitment, it's important as you're screening the patients to make sure that they have the transportation, the time to be able to come in for clinic visits. And again, this is part of the screening and assessing whether there'll be a good participant and if this is a good match for them. Make sure they understand the procedures that are involved. So these are a few sample recruitment materials. These are postcards. We found often that if we do mass mailing, we used to put things in an envelope with a brochure and a letter and so on. People don't open. We don't open. You see something in the mail that looks like an advertisement, often you just pitch it, see where it's from, and pitch it. So we found the postcards, a nicely designed, attractive postcard. All you want to do is call you. So make it short, simple, send it out, and because they don't have to open an envelope, they'll see the message and maybe put it aside and lay it on the table and look at it later. They can also pass it off to friends or relatives who may be eligible. This is an opt-out letter, which just is an example of how you can reach some of the patients of a colleague, a physician in the clinic. Approach that physician and say, we have a study your patients may be eligible for, would you be interested in referring them to us? And you can mail his patients, or he can mail his patients a letter saying there's a study available. If you are interested, someone can contact you. If you are not interested, call this toll-free number and opt out. No one will bother you. This has been a very successful tool and has been IRB approved. And it depends on the study and it depends on the approach and how you word things, but this is a way of reaching the patient population that you don't have access to yourself. And as I said earlier, monitoring your progress is critical to staying within budget and staying on target to reach your goal. And these are some examples. Our system on the right, this chart will tell the number, it shows the number that we've reached, number of calls that were made. Of those, how many were eligible, how many were ineligible, and then the reasons for not having contacted the ones below. And we work these reports. This keeps us on target. We have many other kinds of reports. This is just one sample. The kinds of reports we use reports to monitor our staff internally, but then we have reports for the investigator to show in a quick glance how is the study going. And often we'll have the data. This top left graph shows this study. This was a CMS study. No, it's not a CMS. But it has 8 or 10 locations where we're recruiting people across the state and in other clinics. How many mail surveys were dropped, how many have been completed, and then the reasons for not being completed, and across all sites. And then in the graph, the lower line is the recruitment goal, how many are expected from each of the male drops that dropped periodically to get an even flow for recruitment. And then the middle red line is the number of surveys that were completed. So this gives a quick overview. Is a study on target or not? And then there's another report below about the number of people who were enrolled, how many surveys were completed, how many were ineligible, how many were refused. But this kind of detailed report really is valuable in tracking your recruitment and telling you if you need to increase efforts or if you need to back off or just exactly where you stand and keep you on budget. We have a very robust system and many investigators don't. There are some maybe software packages out there, but it's important, whatever you do, that you have a good system that can track your efforts. Factors for low retention and compliance. This kind of coincides with recruitment. We always try to problem solve ahead of time. But common factors for people dropping out or not being compliant, they didn't get the treatment arm that they wanted. Older people, often retired people, make great participants, but sometimes they have health issues, transportation issues, or even childcare issues if they're taking care of grandchildren. Lower educational level is a risk factor for dropping out. Of course, unemployment, lack of trust, and loss of interest in the study. And loss of interest can be very hard to find out why. And that's where it's important to problem solve with the patient or participant. If they drop out, call them and talk with them and find out if did something happen in the clinic or did something happen with an interviewer or something happen in your life that makes this a problem, and find a way to solve that problem. And it takes just a little questioning usually. I mean, it's easy when we're busy just to do the robot calls or move on, but that's what makes people feel like a number and that, well, they really don't care. No one bothered. I didn't show up, but no one seems to care, so it's on them. So keeping that relationship with the patient, we can't stress enough. It's worth the investment. A person that drops out costs $50 eventually to do a clinical trial. One other thing. If you can have the same staff calling participants or working with them, it helps that build that relationship. So like on a big study, we might have 8 or 10 people working with our recruitment or retention efforts. And we would assign certain interviewers to certain populations. So when Carol called for a reminder call, they recognized her. And that worked for 16 years. They knew Carol's voice or Margaret's voice, and that's important in maintaining that relationship. And then participants can feel comfortable in talking with the staff. So basic elements of retention, we try to prevent dropouts by assessing them carefully before we ever enroll them. And once they're in the study, we try to maintain effective strategies. And if they do drop out, want to withdraw, we try to recover them. So again, this is kind of a repeat. We try to screen them first and identify. The other thing that we did, this was for PLCO and Enlist. These were the studies that we recruited 11,000 total people for. But we would have the interviews, call people, screen them by phone, and establish expectations for the study. And then we would invite them into an orientation session to go through the consent form as a group. And that was kind of another information bonding opportunity. And it also let them hear the questions of other participants, or potential participants. And that was a very effective tool. That's not always possible, but having the time to meet with staff is important, whether it's one-on-one or as a group. And another critical part is to keep them in the study is to make sure that their visits and any interactions are efficient and convenient and professional. So we didn't keep people waiting. We made sure that we had staff there and that we were ready to go. We didn't overbook too much. They're volunteering their time, and so we appreciate that and let them know by making it as pleasant as possible. Give lots of reminders, schedule people before they walked out the door. We scheduled them for the next appointment, so that expectations set. Gave them a postcard, make reminder phone calls, and sometimes send thank you notes. Again, this personal contact is a theme of our approach. Non-monetary incentives. Now, when someone suggested giving a couch piece, I thought, this is ridiculous. That's amazing. But we did it, and it was important for several reasons. It's a simple thank you, and we always put our logo and our toll-free number on anything we gave them. The most effective, most favorite tool gift was a little pocket calendar. It said PLCO and a toll-free number. And once we hit on that, we started getting calls. We would mail them out with a holiday greeting card. And at Thanksgiving, we would start getting a few calls saying, are you going to give us a calendar again this year? Or should I buy my own? And so things like that help. And especially putting your number on it, it's just another reminder. If you can provide parking and especially at UAB, that's very helpful. And in PLCO, we recruited 30% African Americans, and one of our goals was to provide access to people in the Black Belt. That area has few doctors. The cancer screening rate in the Black Belt is way below normal. To provide access to those people for a research study was important. And we were able to have NCI buy us a van in order to support that effort. So we took our van out, we recruited in the Black Belt at churches, at senior centers, and then we sent the van out to bring them in for clinic visits. And we had a guy that would get up at 3 or 4 in the morning, drive down to Butler or Demopolis or Selma, pick up participants, bring them back in, and then take them home again at the end of the day. That was a very unique study, but sometimes there are services available and in problem solving for participants who may have trouble getting in. Sometimes there are churches that in these communities that will have vans that will bring them in, or help them problem solve when you have a sister that can bring you in. But talking about the issue and helping them find a way and to overcome that barrier was very important for our study. Oops. And in recovering dropouts, if someone expressed an interest saying, I'm just not doing this anymore, I'm just not coming in, I don't want to be a part of the study anymore, we would choose the staff member that had the best relationship, most frequent contact, and have them do some problem solving with them to find out what was the problem. Were they offended by something that someone said in the clinic? One time there was a woman, this is from a different study, that said, the doctor just said, well, of course you're sick, you have cancer. And she said she was just so rude, I'm not going back. So the patient told this story to the patient navigator, who then was able to talk with the doctor, with the staff, and reestablish a relationship, and everything was okay eventually. But little things can click in a person's mind, and to be able to find out what that issue was and address it is important to retain a person who has had some change of heart. And you always keep an open door. And sometimes when people said they want to drop out, we would say, well, can I call you next year when it's time for your annual survey, just in case you changed your mind. And often a person was having a bad day or something in their life had happened and they couldn't be bothered then. But after a period of time, they were willing to come back or to reconsider. So keeping an open door is important. You can't continue to pester someone, but if they say it's okay to call me again, it's okay. So that's important to keep that open line instead of just writing them off too early. And for this long-term follow-up, we stayed in touch with 99 or 97% of our participants, 6,118 over 16 years. So this kind of strategy was very effective. It's worth the investment. And we always obtained permission to collect contact information, sometimes of a person who didn't live in their household, maybe two people that didn't, because people move a lot, people get sick, or live with a relative for a period of time, particularly in the older population. So having records with lots of contacts will be glad to do that. So this is the impact study. This actually, the patient navigators, this study was funded by NCI to support clinical trials in general. So we used the 4 patient navigators in the clinics to educate minority patients about therapeutic trials in general, to assist in recruiting them, but also to retain patients that are already in clinical trials. And the way the navigators work is they will be in the clinics with permission from the staff and the physicians, and if a patient is identified as being potentially eligible, the nurse may say, are you interested in talking with, we have a study that you may be eligible for, you may be interested in, would you like to talk with someone about that? And we'll link them with the navigator who's right there, who can talk with them about the study, about clinical trials in general, about the rights and protections. The Tuskegee shadow lingers, and for people to be reassured that there are safety mechanisms and they have rights and protections has been important. Assisting in understanding the consent form and generally working with the staff and the physicians as the recruitment or enrollment process is going on. The navigators will link the participants with social workers or other community services. And they've even gotten free food vouchers from some of the vendors in the hospital. They have worked to acquire some resources to help patients who may have difficulty coming. And generally, the most important thing they do is provide emotional and to know that there's someone they can call without bothering the doctor, because sometimes taking place is not that important. And sometimes the navigators find out serious problems by just checking on the patients now and then and referring them to the nurse or the physician. These are our navigators on the right, and they've been working in the hospital and Kirkland Clinic since 2006. We started with one navigator, Lisa, in the lower right, Kim and Diane and Angela. Since 2007, 424 African Americans have been referred to the patient navigation program. Of those 424, about 378 were eligible for the trial, and of those eligibles, 80% enrolled in the clinical trial. And this was after some contact with the patient navigator. Of those who enrolled in the trial, also enrolled in the patient navigation program, 70% enrolled in patient navigation. Of the ones who enrolled in patient navigation, nearly 75% completed the trial, compared to 37 to 38% of those who did not receive patient navigation. So the navigators have been very effective, both in helping enrollment and in retaining low resource patients. So kind of just to recap the recruitment and retention of our services, we like to work with investigators before they write a grant. We can help with the recruitment plan. We can provide some boilerplate that demonstrates often young investigators don't have a proven track record, and having access to our resources can boost the strength of the proposal by showing that they have access to recruitment services that have been successful. But we will work with anybody who needs help recruiting, and they don't have to be members of the Cancer Center. We're open to any faculty in the U of E complex. We can reach participants through our mass mailings, as I said. We can conduct all kinds of other activities, clinic recruitment, phone surveys, focus groups. We do qualitative face-to-face interviews. And again, the cornerstone of our success is our data system. Also, we have 20 years of working with the community and know how to reach minority communities, participants. We are cost effective in the long run and efficient, and we can help you meet your recruitment goals. But these are some of the ways that we have been successful, and I hope this will be helpful to you. Feel free to call us just to consult or to actually recruit your participants. So do you have any questions or discussion? Sorry, I didn't mean to take so much time to leave you some time to talk or ask questions. Yes?
It seems like the amount of time you may devote per study subject could vary a lot. And how do you predict up front what the cost of your participation in the study is going to be to an investigator team? Is it handled in a different way?
Yeah. The retention is less predictable, but we'll talk with the investigator to see what their study is like, what their needs are, what they've been doing, and what they think is needed. And then we'll kind of come to an agreement. For recruitment, we've been doing this a while, and we just kind of crunch the numbers and come up and look at their the investigator's budget, say this is how much you've got, this is what we think would be most effective, and come to an agreement. It's a joint effort because most investigators know what they need and may not have all the details down, but we'll work with them, and it isn't always a clear-cut. I mean, as you know, recruitment some things work, some things you think will work don't, but that's why it's important to change strategies before you waste a lot of time or a lot of money. And we charge for our effort and materials. So we're not that much more expensive if a investigator has to charge their own, hire their own staff. Sometimes it's easier to come and use our resources for several hours a day or whatever it is than to hire someone with expertise in that area. So that is one of the benefits. But we'll work with the investigator and try to come up with a plan and set limits so that he knows what his obligations are. We have a letter of agreement, and we'll say, this is what we will plan to do, this is how much we expect it to cost, and if that changes, then we get back together and talk and say, that's kind of our process.
We have something that we call a scoop sheet. And I think, just thinking through that, one of my notes was thinking through the process. We usually will meet with the investigator or their designee and go through that scoop sheet. What is it that you're trying to do? How you're trying to accomplish this? And sometimes our conversations lend itself to, I really thought I needed to do this, but in talking to you all, I really only need to do this. So we can scale down or we can scale up. A mass mailing, I need you to do mailings for me. It's going to cost far less than it would be. I need you to recruit 400 people. And so we think through those processes, get with them, develop a quote for them, then get back with them again and say, what do you think? What is it? When they look at it, they say, well, what is this? Do we need to travel? Do we need voicemail? Do we need all of these components? You have to think through in that process to actually build a quote that's acceptable to the investigator and trying to work with them in every aspect of their recruitment.
Yes. Have you all done any re-recruitment? There was a study here in the late 1990s, early 2000s. We're looking at contacting those patients now and doing long-term follow-up. So have you done any re-recruitment of old subjects?
We're getting ready to do that. With the National Lung Screening Trial. That study stopped and ended in 2011. Those were heavy smokers, age 55 to 74. We followed them for 5 years. Actually 7 years. And now we are going to be going back. But we're just doing National Death Index and cancer registry searches. But we did, but we're not going to be reaching them. We haven't gone back. And you have to pretty much, if you haven't got a consent that agrees to follow up, you have to reconsent them. Unless you want to do an anonymous, de-identified kind of search. Well, that won't be yes.
I'm from district, and we have done a study where we went back to find subjects. They were preemies that were treated with the drug, and we wanted to know 5 years later, 10 years later, did they have cancer, just because of the nature of the drug. So what we did, it was a multi-center study. We did get IRB approval, but the process was we had connections with the principal investigator, and most of them were also the PI, attending physicians. And we asked them to present the possibility of doing the study to their subjects so that we weren't contacting them with their clinical doctor.
Yeah.
And that was how we got, and then they then signed a consent, and we were able to have them come in and do some additional processing. So they're, our creative ways, I think, of doing.
Any other questions or issues you may have had during recruitment that you might like to give a little feedback about? Latest penny gesture story.
Yeah, so just before we take a short break, I just want to sort of reiterate what Darlene said, that generally the CCTS really encourages you to think about trying to take advantage of shared services rather than setting up your own staff to do things that ends up, you give up some degree of your own autonomy, but you gain a lot of experience that exists around the campus, and you avoid paying for people's time if you don't need it. You get what you really need. That's what you push it. Thank you very much for doing this. We'll take a 3-minute break.
Remote listeners. Is this your presentation here? Oh, right, okay. Hey, nice to meet you.
Yeah, it's good to meet you. I think I've met you years ago. Did you have long hair?
No.
Okay, used to be clean. Oh, okay, all right. Well, good to meet you. Yeah, good to meet you. You work with Margaret?
I did.
Thank you.
I started with Adam Margaret.
Okay.
He's trying to fix something.
Great.
Thanks, yeah, he's fixing it now. He's got to sign in. It's
So, I could have a few people. So, you have something. Okay, thanks, Mike.
Battery died. And my mom.
Sure. I'm going to make a couple of announcements just while we're regathering. I don't want to take up more of the speaker's time. So next week, the session will be led by Tom Huddle, who's a professor in the Division of General and Internal Medicine. He's has a PhD in history of medicine and is interested in professionalism and bioethic issues around clinical research. He's going to have a much more interactive discussion. I'm not trying to steer you away. It's actually a great session. But it will be much more effective if you take half an hour or so to read some of the material that he is going to put online. Jean will be sending you an email to tell you how to access that material. And so I really encourage you to look at least some of it. You'll be much more able to participate in the discussion next week. So have an eye out for that email that will be coming soon. Okay, so the second part of the session today is led by Penny Jester. Penny started out as I guess a practicing pediatric infectious disease nurse. Her appointment's in the Division of Infectious Disease in the Department of Pediatrics. She's a certified clinical research coordinator. She has a master's of public health, and she's really interested in educating people to perform effective clinical trials and to do this with what's called good clinical practice, or GCP. So she's going to give an introduction. She runs a part of the CCTS. I guess she's co-director of what we call CRISP, or Clinical Research Support Program. It's one of, she'll tell you a bit about it, I'm sure, but it's one of the ways in which the CCTS tries to help people who have intermittent needs for support staff to run the clinical research, so you can buy people's time to do various aspects of the program development. She helps with writing IRBs, with drug investigational drug advice, write-ups, all kinds of stuff, and but they can also provide staff to draw samples, to do all kinds of stuff. So she'll tell you about that as well as the topic. Okay, thanks.
Thank you. Thank you all. I am delighted to be here. Let me, oops, very sensitive. I'm going to give you a quick introduction to who I am. So as David said, I've been around UAB for about 19 years doing research. And my history was a pediatric intensive care unit nurse, and then I worked at the VA, then I did home care, so my undergraduate was nursing. Went back to get my master's in public health thinking, oh, I just want to do better at being a public health nurse. I got sucked into research, started in doing behavioral studies, so I've had experience doing that. I actually worked on the 5-a-day project. If you know anything about that, it's where we were trying to teach elementary school children to eat 5 fruits and vegetables a day. And so my job was to go in and collect data. And collecting data was standing in the cafeteria in a public school, writing down what kids were eating. So that was quite an adventure. I've evolved. Went to the emergency department, worked as a coordinator for a while, and then actually did some studies with pigs. We were doing some blood loss studies, and so we would be in the lab. So I've had a bit of that as well. Primarily from the time that I did get my master's and then came into the hospital and into the UAB working with more clinical care, I realized there was just a big void in education. You know, when you go to school, you get your MD, you might even get your PhD, but you don't learn how to implement a clinical trial. And as hard as it is to write a study, to get funded, then you have to implement it. And that's sort of where I have focused my interests, and that's where the education realm has come in. And at the end of this, I'll tell you about other education opportunities we have here at UAB. What I'm going to talk about, and I could talk forever, I'll try not to do that. And so I do have a cell phone here, but it's just for my time to keep myself on time and not to go over. If it rains, I'll apologize, but I don't think it will. I'm going to talk about good clinical practices. And really, this is all about implementation of a study. How do you implement it? How do you implement it so you don't get in trouble? How do you implement it so you get the best data? How do you implement it so you protect your human subjects? That is really all GCPs are. When I first started in research, people said, oh, just follow the GCPs, and I couldn't find them. There wasn't one document, and that's true. There's not one document that tells you how to do it. So GCPs is really an aggregate of a bunch of documents, and I'll talk through that. But the one thing I would say that's really important for you as investigators is to understand the regulations, to understand what's required of you. And let me give you one example. So under one of my hats, I am in pediatrics still. Part of my time is overseeing the Collaborative Antiviral Study Group, which is a NIH-funded coordinating center type of program where we do antiviral research on children and adults, but not HIV. There's another bucket of money for them, so they take care of that. So we do HSV, West Nile virus, flu. We've done a cadre of things over the years. And so we act as a sponsor. And we have at the current time, we have 38 sites around the U.S. and the U.K. We have 5 studies going on. We're starting 6 months soon. And so we act as a sponsor under a contract to the NIH. Years ago, we were doing a study with cytomegalovirus and using valganciclovir, and it was in children. Study closed, we had great results, but the issue was it was an FDA, it was under an IND. So we had a site in Texas who was our highest enroller. So they, of course, sadly, when you're successful, you get audited by the FDA. So it was a pivotal trial, and that's another reason the FDA might go out. So they had gone to this site, and when the inspector got there, well, we had gone early because we go to prepare the site to make sure they're ready for the FDA. The NIH was involved in getting them ready for the FDA. The inspector's there. Suddenly we get a call from the site, and they said, they're looking for the remnant drug. Well, the issue was, in our protocol, which was approved by the NIH, it was approved by the FDA, we had said you can destroy the study drug after the monitor confirms the accountability, because every child had their own bottle. Well, this inspector thought this study was a bioavailability study. And we panicked because we had told them to, and if you have a bioavailability study, you're supposed to keep all the remnant drug. So I felt awful because I thought, oh, we've told them the wrong thing. We are going to get in so much trouble. And the NIH, I thought the NIH is going to get in so much trouble. The bottom line, it turned out, the good part was it wasn't a bioavailability study. But had it been, that investigator would have been solely responsible because he was a principal investigator. It didn't matter that the NIH was telling him to do one thing. It didn't matter that we at UAB were telling him to do something. He, in fact, had taken the mantra to be the PI at that site for those studies, for those specimens, for that drug, and he would have been held accountable. I was pretty shocked. I didn't think, we probably wouldn't have gotten away scot-free, but then again, the fact that the PI was doing what we told him. That just reinforces to me that understanding the regs is critical. Having a team that helps you understand the regs is equally critical, and sometimes even more so. How many of you are physicians, MDs, and PhDs? Many times MDs especially have conflicting interests because you have patients to take care of them. So to have someone who's going to help you manage your studies is really, I can't encourage you to be sure to do that. Don't try to do it alone. I can honestly say I've been in research 19 years, and every year I have a new every day I have a new challenge, and I'm always calling somebody to get advice, to get guidance. The IRB is fantastic. I freely call the IRB, and I said, well, what do we do about this? And they help. OSP, just everybody on campuses should be willing to help you, and I think you will find they are. But don't feel like you have to have all the answers, because you won't. And you may not have them in 20 years, but you'll be closer. So let's see. Oops. I'm not sure. Let me see. Maybe if I get the right button. Oh, I'm sorry. I don't want to end the show. There we go. Let me just do that. Yeah. There we go. All right. So what I'm going to talk about is what the importance of GCPs are, why they're important, what they are, when you implement them, and who implements them. So what do good clinical practices mean? Again, it's a generic term. It really has only 2 meanings. One, the best practices for collecting the best data, and the best practices for protecting your human subject. And they come in many varieties, in many shapes, in many forms, and we'll talk about that. But generally, if you can abide by these 2, every step of the way, you are going to be fine. I think you heard about this, you saw this slide earlier. I think it's one to imprint on your brain if you can. But research is a systematic investigation, including research, development, testing, and evaluation, to develop or contribute to the generalizable knowledge. The key words are systematic. Again, in collecting data, you want to do it the same way every time. You want to follow your protocol every time. And generalizable, again, that's the whole point of research. Clinical care is a one-to-one thing. A doctor, a physician, takes care of the patient, and that patient and the doctor determine what the best care is for him. In research, it isn't a one-to-one. And I've heard it described, it's a public activity. It is something that you're doing to provide generalizable information. So what's the difference between human subjects protection and GCPs? Not really a lot. One could argue that the GCPs are kind of under, or the IRB is sort of, or IRB approval is sort of under GCPs, in that that's the protection of human subjects. It's much more than just saying that, but as you've heard about you've heard a presentation on the IRB, but it's, again, the IRB doesn't talk about collecting good data, though ethically, if you don't collect good data, they're going to worry about it. You know, that's going to, the ethics part of data collection is under their realm. But sometimes people say, well, I've taken a course, the HSP Human Subjects Protection course, shouldn't that take care of everything? It really doesn't. It doesn't, the GCP adds to the knowledge of how to implement a study. The definition of a clinical trial, again, this is everything that I'm talking about, GCPs, and also, as you know, with the IRB, it's all about human subjects research. And the current definition of NIH, you know, it used to be that a clinical trial was just a drug study, but it's not. We're looking, the NIH is expanding it to be behavioral studies, any interventional, anything you're doing prospectively. It's really, that would be considered a clinical trial. The impact of GCPs is pretty clear. It strengthens the ethical and scientific standards when adhered to, and enhances the quality of research. So where do they come from? You know, much like the IRB guidelines, they come from mistakes we make. There's no law. I think about it. I bet there's not one law that we have in this country, in this city, that wasn't written because of something stupid somebody did. So, in fact, that's how GCPs are. They're designed because of, they've been written and provided to help us stay on track with what we're doing. In fact, there was an event that took place, again, in research, it's constantly evolving. You know, we often talk about Tuskegee and how that prompted the Belmont report and how that prompted the development of the IRB framework. So as bad as Tuskegee was, we took what we could from it and learned. I think every year there's something new that happens and causes us to rethink how we're implementing research. If you think about it, there was an event probably 3-4 years ago, and it was in the press. It was called a support study, and it was where there were children being enrolled, newborn preemies being enrolled in a study that was trying to determine what the best oxygen saturation was for these newborns. You know, the standard of care was 85 to 95, and they were trying to compare 85 to 90, 90 to 95. Well, to make a long story short, what evolved was there was question, the consent form was questioned. And so for that reason, what has happened is then our IRB decided, well, let's get a little bit more rigorous about how we describe the risks for each of the groups. You know, many times in the past, I guess we've often lumped all of the risks under one, you know, under the risk section, just being in the study, but then to define the difference in two groups. It was good, you know, it was, I think, all in all, it has all worked out well, but we learned to be a bit more rigorous about how we design our consent forms. So there are new regulations, there are new requirements coming down all the time. And there's the common rule is being changed, and I won't go into that, but that's one thing that helps dictate how research is conducted and how we get our approvals. But, so there are two primary major sources of what I would call GCPs, and one of them is the Code of Federal Regulations. The other is ICH GCPs, and you can find them online. I have these books if anybody wants a copy. Now, I might not have enough for everyone, and some of you are probably wise enough to not get a book and just use the internet, but if you want a book, I'm still old. You know, when I first started in research, I worked with a colleague at the NIH who said, you know, hers is just, you know, I had just started in research. She said she had stickies all over hers and marked all over it, and I thought, I hate reading this stuff. Years later, mine looks that way because you really, really need to use it as a resource and just have one at your fingertips somewhere. And again, keep in mind, it's a guideline and it's interpretable. All of the regs, they're not black and white, but they're interpretable. So, anyhow, just as an FYI. So the Code of Federal Regulations is in here. again, we are bound by law by the Code of Federal Regulations. It is still considered a GCP in theory, but it is a law also. It's more than just a guideline. These are things you have to do. And then there are the ICH GCPs. And I will tell you, and I'll show you a few slides here. There probably are going to be a number of slides. I won't read through. You can read them at your leisure. You don't need me to read to you, but they're nice resources. There isn't a big difference between the ICH GCP guidelines and the Code of Federal Regulations. But ICH GCPs are a whole lot easier to read. That's one of my weaknesses. I'll probably go there first, and then I look at the Code of Federal Regulations. There are some differences, but not major. What happened was the ICH, so the U.S. has had federal regulations for many years, and we in fact they've been developing over time. I think in the 80s, the ICH GCPs began to be developed, and this was for international research. If you think about it, if there's a study that's being done in Europe, we want to make sure that if they do the study according to some guideline, we can accept that drug in our country without having to go through all the same studies again. So accepting how the studies are done. Many protocols, if you look at them, we have some studies that, because we're doing it in Europe and in the U.S., there's a page that called compliance. It's a page in the protocol that says in the conduct, basically it says, in the conduct of this study, we will adhere to the Code of Federal Regulations, we'll adhere to ICH GCPs, and because we're doing it in Europe, we also have to comply with the EMEA guidelines. So again, look in your protocols that may be given to you by sponsors or that you're developing. There should be somewhere in there what guidelines you're going to follow. If we were just doing a study at UAB, we probably would only worry about the Code of Federal Regulations. You really wouldn't necessarily have to write in the protocol that you were adhering to ICH GCPs, though I would encourage you to do it anyway, because it's becoming more expected that everybody who's doing research has ICH or has GCP training. And again, GCP encompasses everything. So it's interesting, I have to tell you, most of these countries accepted ICH GCPs as their law. In the US, we don't accept anybody else's law. We'll accept them as guidelines, but we want to keep with our Code of Federal Regulations, which is fine. But it just we have participated in the development of them, but haven't adopted them as rigorously as other countries have. So GCPs are, again, just kind of to break it down, if you look at, as I said, it's a cadre of guidelines and documents. The goal of any GCP is protecting human subjects and collecting rigorous data. Again, our primary points to remember. Sometimes there are laws that require, it's an obligation. There are regulations that support GCPs, the Code of Federal Regulations, there are some mandatory requirements that may be required by law. Guidelines, ICH GCPs for us, they're a guideline, the Belmont Report, Declaration of Helsinki. They're guidance documents, DMID might be your sponsor guidance document, IRB guidance, SOPs, information sheets. And then there are the cadre of other documents that are very protocol specific, your training, your audit, and compliance manuals. Again, all of those contribute to what would be ways and means to protect human subjects and collect good data. Again, just sort of a pyramid appearance of these different tools. As I mentioned, there's a primary source. The next few slides really talk about the difference between, just some bullets identifying the difference between the GCPs and the ICH GCPs and the Code of Federal Regulations, which is the FDA. Again, if you example, I'm not going to read all of them, but ICH GCPs, they define the use of the word witness as just somebody impartial, and what subject's witness, again, the subject's witness attests that the subject signed the consent form. In the FDA guidelines, again, under FDA Code of Federal Regulations, it says the witness line is just for the illiterate. But we use it. We may use it for more than that. But just so you know how things are written. and how they vary between the two. Nothing significant though. I think you would find that, they mirror each other pretty well, which makes it easy for us. So these are, when are they implemented? Every step of the way. When you're writing a protocol, you're going to worry about subject safety. You're going to worry about how are you going to collect the data. Conducting the study, no different. You're going to still apply the GCPs, monitoring, auditing, recording, analyzing, and reporting of clinical trials. So, who implements them? Everybody. There is not one person on the study team who shouldn't be implementing them, who shouldn't understand how to protect subjects and how to collect good data. Even the person who's answering the phone, screening a subject, that person needs to understand the importance of dealing with study subjects, the importance of confidentiality, the importance of what she says. That person answering the phone is not going to say, oh yeah, this drug is really going to cure you. You need to make sure that everybody interacting with study subjects understands the principles of protecting subjects and collecting data. Competencies. You have I believe, have a copy of the manuscript that came out 3 years ago, I think it is now. One of the movements in the U.S. is to develop certification for investigators on really GCPs, and it's very rigorous. And if you look at that article, they haven't been implemented yet, but it provides a cadre of things you should know in order to conduct good research as a rigorous investigator. There is even a movement whereby you would have that institutions are going to be awarded protocols, awarded studies based on whether their investigators have this certification. We are not there yet, but I think it behooves us to be prepared. And so one of the things we're doing at UAB is developing classes. I mean, we have a class for coordinators. It's roughly 26 hours long now. We've added a few hours to it. But again, to teach them all the things they need to know on how to implement the study. We've started some investigator training programs. We just started our first one last month. There's a research orientation program we have. But we're starting to build training courses here at UAB on various aspects of conducting studies that would help you enhance your ability to do research with the expectation that we're going to end up with these competencies at some point. So the competencies, just what are they? They just show that you know what you're doing. There's several definitions here. But as a professional, you need to be you need to understand what you're doing. I know that historically, as a coordinator, it was not uncommon for physicians to hire a nurse and say, oh yeah, you just need to do this research study. Nobody teaches you how to do research. Nobody teaches you how to implement a study. You don't learn in nursing school, you don't learn in medical school, you don't learn when you're getting a PhD. So that's why these courses are so important. And you need to increase your competency in what you're doing. There are current work groups that, again, put these competencies together. I'm not going to read through that. The CTSA had developed some early on. And the APPI, everybody is pushing for this concept of competencies. And again, they're all GCPs, one could argue, because they all are going to lead you to conducting better research. So the competencies encompass these 8 domains. Leadership and professionalism. You should know how to lead a team. You're not in this alone. You need to know how to work, because you're going to end up working with the IRB. You're going to work with someone collecting data. You're going to work with your data manager. You're going to work with your pharmacokineticist, possibly, or a pharmacologist. Understanding how to work in a team is critical. Data management and informatics. In the studies that we do, since we had the opportunity to actually be the sponsor of the study, we had to work with the data folks to build databases. We had to build our own case report forms to collect the data on. And as much as I hate doing that, I have learned so much about the importance of data management. It's one of the most underrated aspects that we do. Does David Redden talk to you all? Is he on? Not yet. You will. He'll talk about data management, and there's nobody better who can do it. But it is again. I do think it's always underrated. We're working on it. We're working with an investigator right now, and I won't mention any names because, well, let me step back. So as David mentioned, I also oversee the collaborative clinical research support program, where we provide nurses, non-nurses, regulatory people, data entry people, monitors to anybody on campus. Now there's a fee, but we would work with you on that. But we provide because as an investigator, you don't have all those resources at your fingertips usually. And many times investigators will want to start a study and they only are going to be able to pay for like 20% of somebody's time. You can't go out and hire somebody for 20% off the street and expect them to be competent. I mean, it's a really hard thing to do. So we have people available for 20%, 30%, because we're all over campus. This investigator had written this protocol. He didn't have David Redden help him with it, so it was a little bit slack in a few areas when it came to data collection. But they were getting ready to start the study. They didn't have their case report forms put together. They didn't have the database built. They didn't have a lot of things done. And he just wanted to barrel on ahead. And we kept telling him, no, don't do it. We're into the study a year now, and we're having to stop it so we can clean up everything. Because we didn't take care of the data management before we even started. We didn't figure out what forms we were using. We didn't have the database built. Data didn't get entered. The DSMB was upset because when they asked for serious adverse event reporting, there were reports. There was not a database from which to extract it. So, again, it's all part of implementation. Have all your ducks in a row before you get started, and then adhere to whatever you say you were going to do. Study and site management, skills that are critical. You know, how do you manage your site? You know, how are you going to manage your team? Just on it's a very small thing, but if you're doing a study, meet with your team at least once a month. Meet with the people who are working on it. Say, what's going on? Where are we failing? What's our recruitment? You know, constantly be reevaluating what you said you were going to do. You as principal investigators are responsible for that entire team. You're responsible for whatever they do or don't do. You can always fire them, but you're still going to be responsible. So clinical trial operations, really just that sort of means just the operationalizing of getting your budgets done, making sure your budgets are adhered to and built, and that somebody is managing those. Let me come back to this in a minute. If you're doing drug studies, medicines, development, regulations, know the regulations if you're doing a drug study. You have to have drug accountability. You need to work with your pharmacist. You need to make sure the research pharmacist has the drug, that they're keeping, although the research pharmacist is supposed to be doing drug accountability, if they don't, you're going to get in trouble. If it's a device study, there's management of the device that you may delegate to someone, but you need to understand what the sponsor expects you to do with the management of that device. Ethical considerations and patient care and safety. Again, I almost don't have to say anything about that. If you're dealing with human subjects, I always say the most important thing here is tell the IRB what you're going to do with that human subject. They're kind of your protection in so many ways, because you can do a lot of things, but work with them to do it the right way, to make sure that you have every protection in place possible. Scientific concepts and design, I've kind of gone about this backwards, but that's what you really do when you're writing your protocol. Know what designs are most ethical for your subjects, that will get you to the answer you want. One of the other things that comes out of my office is we manage INDs. Well, we will help if asked to develop INDs for investigators on campus. And we will work with you to get it put together, and you just have to bring the science to it. We're working with a couple of investigators right now, and it's not really going well because they have decided they're not too worried about the science, they just really want the money. So again, we're trying to get them focused on the scientific aspects of what they're doing, but it seems a little bit challenging to them right now. Again, this is something that, again, out of my office, we don't do too much with the design of studies. I know that the CTS is here to help you with that should you decide to write a protocol. So in clinical trials operations, it's really everything. If you look at that manuscript, it takes each of these and breaks it down into components. So what we're trying to do with all of our education programs is again, address each of those and bring them to the forefront. The next few slides are just basic, scientific concepts and research design. Again, just expanding on a little bit of what I've just said. We have done, and I think one thing you need to understand too as an investigator. One of the things that I don't have on my slides is, and it really has to do, I'd say, with the research design. The word protocol deviation is something that people cringe about. I would encourage you not to do that. Don't cringe about it. It's a good thing. Deviations, they can be bad, but the thing about when you're doing a study, say you've written a protocol and you're going to collect blood once a week for 5 weeks on 15-year-olds. Well, you learn shortly after getting into the study that they're not coming back every week, they're only coming every other week, so you write a deviation. You have some kind of document where you can keep track of what was missed and why. And then you go back and evaluate and you say, hey, maybe we don't really need that every other week blood draw. The deviations give you justification for changing your protocol. Deviations also are when subjects, when maybe you did something wrong, use them as a tool to improve what you do. I think as you go through conducting the study, constant evaluation, recruitment, are you collecting all of your data? What are you missing? Why are you missing it? That is all part of getting good, rigorous data. And it's very important to a study. So I know a lot of people just think protocol deviations are the worst thing possible. They're not. They can be, but they're not. The issue here is about adverse event reporting and identification. Again, we were going to start a new study with a company, new startup company out of North Carolina, had a great drug that had high antiviral activity. We were going to use it for a couple of studies, and this was about 3 years ago. And initially, they said they wanted to give us the drug. What we do with our NIH studies is the NIH gives us money to do the study that they like, because it's a contract, it's not a grant. And then we partner with a pharmaceutical company who might have a contract with the NIH, and the three of us work together. Because then the NIH will they'll buy the drug for us. We met with this company shortly after we were awarded the contract, and we sat down to dinner because we were socializing the night before. And the medical monitor for the company kind of looked at me and she said, okay, so now when your investigators call you and say they have an SAE, would you please call me? Because I want to talk to them about that. All right, think about this. Pharmaceutical. And then for the rest of the dinner, they talked about how much money they were going to make. We were totally unnerved because it was like, okay, you own the product. You as a medical monitor for the company are going to interfere with the thought processes of the principal investigator to tell him how to or how not to report an SAE. And we told them we would never do that. But I say that as the importance of SAEs. They are important. If an SAE occurs, it's got to be documented. Some people think AEs and SAEs are bad, but they're not. They're all part of the development of a product. Interestingly enough, this is a product that we are finally going to be studying. It's taken us forever to get there. And suddenly this company, they had a big turnover. They had a phase 3 study testing it in another indication where they had to shut it down because of the number of deaths. And it was higher in the the population that received the active drug. So we had several calls with the FDA to say, can we go forward, because we're using it in young children. We're using it in a whole different population, and we have a lot of stopping rules that will keep us from going too far. But I think I bring that up because those SAEs are important. Collaborating with the FDA, and they will talk you through if you end up with an IND and you're doing a drug study, and it's you're the lead PI. They will work with you. Because they worked with us, and we all came up with better ways of assessing SAEs, looking for different signs. that may be indication of more problems coming, and everybody was quite happy, but it's not a solo activity. It is just not a solo activity. But again, the reporting of AEs and SAEs tends to be solely in the responsibility of the investigator. Most of the time, a coordinator might identify an event that's out abnormal, but it's the investigator who has to make the determination of relatedness, seriousness, because that's a very clinical aspect. So, anyhow, just a very important part of managing a study. I will tell you, again, I can go off on tangents, but financial is important, darn it. I hate finances, I hate dealing with it, I hate invoicing, I hate having to deal with all of that, because it's not science. But it justifies what you're doing. Everything costs. You know, you may have somebody say, oh, I'll come in and do that for you for free. Well, that's really not a good thing to do. We have to know the true cost of research. And it's important in the development of drugs, and or anything we do. And just a little side note, has anybody done any pharmaceutical studies? Does anybody envision doing any pharmaceutical studies? Well, so a couple people raised their hands. But developing those budgets is really important. And you've got to cover your costs. And the one thing I would always tell you, and even if you're writing your own protocol, the most important thing you can do is do not overestimate the number of subjects you're going to enroll. Be sure you're real about it. If you're doing a pharmaceutical study, if anybody ever gets into that, then one of the most important things to do is not to overpromise. You are far better, say you're going to, you're approached by a pharmaceutical company, they have a drug they want you to study, and you think you can get 50 subjects. Maybe they only want 10 or 8 to get you in the study. You're far better off promising 8 or 10, getting those, and then asking for more money to keep going. If you promise 50 and you only enroll 8 or 10, there is and I will tell you, there is a master database, we understand, between the pharmaceutical companies, kind of giving investigators stars and not stars. So if you're successful in enrolling, that gets you, I mean, in theory, gets you a star. If you fail, then you get on, you don't meet what you promise you're going to do. It can become a negative. As we move toward, again, this whole thing about national competency testing, certifying institutions to do research, your ability to successfully conduct any study becomes part of that record and gets part of the, so it's important to just do what you say you're going to do. It is always hard to identify how many subjects you're going to enroll, I think. That's one of the biggest challenges. We worked with an investigator who was sure he would get 25 subjects, had all the names lined up. He said, yes, they're all my patients, I'll get them in this study. He's enrolled 2. Because the nature of the study was such that people didn't want to participate. He forgot about the fact that some of the folks, although they met all the criteria, they lived 2 hours away, and they didn't want to come back once a week to UAB. And so they didn't sign up for the study. So when you're writing your protocols, and again, these don't even have to be pharma studies, think about that. Think about how are you going to get your people back? Do you need to put in your budgets costs for travel? Do you need to put in your budgets costs for overnight stay at UAB or from the hotel? Again, sadly, finances are important. Mentioned data management, quality control, developing mechanisms within your own office or your own study group about how to QC your data, how to make sure your data is accurate and complete. I think more than any other aspect of what we do, the whole team, I think Anthony could maybe speaking to you, but the whole concept of team science and working together is really paramount. A strong team will be really successful. And again, you're not going to be able to do it alone, but work with your staff. Have everyone engaged. Constant communications. Does everybody know what a monitor does? Well, there's usually, even if you're doing an investigator-initiated study, you may have an external monitor. It's like an auditor, but if there's no penalty, they really should be coming to review your data and say it looks good, you're doing a good job, you've got all your regulatory documents in order. but they're there to help you. So again, sometimes monitors or CROs get bad names, but they really, and sometimes they act like they deserve that bad name, but other times their whole purpose is really to help. Again, professionalism is a whole part of what we do, and where we should be, how we should be managing our research. It's interesting as we enhance our GCPs and again do our research better. These are just some numbers that are really quite striking. $70 billion annual is clinical research is a $70 billion enterprise, and about 30% goes to waste. One drug can take 10 to 15 years, and that's, I have another slide where we talk about, if it's a drug study, about I think 5,000 drugs might enter the pipeline at the end in the development, preclinical, like even in the lab. Only one of them makes it to being a drug that's applicable to the public. And that's one of the reasons for the high cost, because you have to pay for all this other studies that fail. Yeah, and it's challenging. I think going into research and not understanding the challenges is what really is the demise of many young investigators. Because if 70% of the sites will conduct one trial and then quit, it's because they haven't prepared. They haven't gotten the team together. They don't know enough. They don't know who to call. Because I will honestly say, again, calling people is what you have to do. You just have to figure out a way to network and get the information that you're missing. Find people who are experienced and follow through with them. Again, it is a business. Research is a business, and we need to be thinking of it that way. Because, historically, when I started in research, it was just the tail end of, we have lots of money, just hire lots of people and we'll do the research, without thinking about the fact that the research needs to be paid for the staff. And now we're at a place where every minute of our time should be paid for from someone. There's not a cushion in the departments and divisions now to just be used to cover someone's time for sitting around or someone's time for doing research. It is a business. I rather like this slide, and this is the best quote. The purest form of insanity is to leave everything the same, and at the same time hope that things will change. Because they don't. This slide here, and it's kind of hard to see, this has to do with FDA inspections. And these are domestic and foreign, and the issues that come up. 47% of the domestic inspections have problems with the protocol. 31% of the domestic inspections have problems with with record keeping. 15% with consents. 13% with drug accountability, and just 3% with adverse events. The other line is for foreign. It isn't that much off. But I think, 47%, what that simply means, if you go on the FDA website, you can actually find warning letters. These are, once you get inspected by the FDA, that letter, the letter they send you, can be posted on the internet. And you can see what other people are getting dinged for. And again, so what you can identify is that most of it's protocol. Consent is 15%. Now, I will tell you, because we are a coordinating center, we also oversee monitors that go to our sites. And we have one study that the sites have all been monitored. And of those monitor reports, I think 50% of the monitor reports reflect there are problems with the consent. Again, we don't have enough time to go into this, but when you're consenting a subject, not only are you reviewing the consent form, but you have to document that you did it right. You have to document that, because the FDA will criticize you for this if it's an FDA study. You have to document that you gave the subject an opportunity to ask questions. You have to document you gave them a copy. You have to document that, let's see, let me think of that. You did not start any study procedures before they signed the consent. I think there are several others, but again, we have a checklist if anybody's interested that we offer put with all the consent forms that when you're consenting someone, you can check off if you did all those things. But again, that's documentation that the FDA would look for. They want to know, that's how they determine that you consented properly. And even in the behavioral studies, you need to document, even if it's not an FDA study, you want to be rigorous. We've been working with a national group with the CTSA who are trying to build these training programs for GCPs. And there was a point where those folks who were doing behavioral research or social medicine said, social research, said, we don't need to adhere to GCPs. That's all for drugs. But it's not. If you think about our domains, the only one that wouldn't apply would be the medicinal. But everything else, collecting data and picking subjects, it's the same no matter what kind of research we do if we're ever interacting with subjects. And again, I think I said this, but if you ever get approached by the FDA and they call you and say, we're coming, call the IRB, call your sponsor, let everybody know. Everybody's willing. I think even the IRB will come out and help you prepare. The sponsor should send someone to help you prepare. It's an NIH study. They'll help you prepare. You will survive. And the other thing is that one of the things that the FDA looks for, too, when it comes to, I think this is very important, they know you're going to make mistakes. They would rather see that you found a mistake yourself and you corrected it. You said, oh, look, we missed this data. That's rather simple. I'm trying to think of something more rigorous. We incorrectly enrolled this subject in a study. This is what we did. We are doing now to correct ourselves, correct this problem going forward. The FDA likes that because they know if you had perfect records, they'd be really upset because you can't be perfect. You're not going to be perfect. It won't work. But if you identify and self-correct, you identify and figure out corrective action on your own. Anyhow, that's a very important thing for the FDA. They won't get mad at you for that. They will accept it. Again, the most important things to remember, again, remember the definition of insanity. Just get it fixed. Work on your education aspects with your team, building the competencies. And to follow up to that, the one thing I would say, these are the programs we have going on at UAB. And I'm going to get with Jean and get your email addresses because I'm sure she has it. And I can send you when and where all of these are in case you're interested in any access that you might need. The Miami CITI is on the website, but I would recommend everybody do the GCP training if you haven't. Has anybody done that? Good. Everybody should do it. It's more a primer. It's really didactic, but it'll get you the basics of every aspect of GCPs. Most of what I've talked about, but some other things. We have a research orientation program that's every month, the last Thursday for 4 hours in this room. And we just go over the basics of what do you do before you start. You've already got your protocol written. Keep in mind, none of this is about writing a protocol. None of this is about getting funding. But this is so you've got the funding. What do you do before you start? What do you do during the study? And what do you do after? Very brief. It's 4 hours because it's a lot of information. The research team training program was actually designed about 10 years ago. We started it 10 years ago. We offer it twice a year, 4 hours every twice a year. It's twice a year, 4 hours every Tuesday for 6 consecutive weeks. And then we've added a 2-hour session for team science. It was designed for coordinators, but we encourage, but it's not. It's for regulatory people. It's for financial people. The more we understand about the big picture, the better we will do our own jobs, and that's kind of how we approach this. So if you have a regulatory person, they could come and again, learn the big picture, but also learn in detail what they need to do. We have had investigators come, and I guess I would wish all investigators would come, because you're over all these people. You are over the people who are going to be doing the regulatory possibly, over the people who are going to be doing the coordination. And it would behoove you to understand their responsibility, or what they can do if it's your responsibility. We just started last month the clinical investigator training program, which is 4 hours. I don't know when the next session is, we need to get it on the calendar. But it's just 4 hours of focused heavily on principal investigators and investigators' responsibilities. And then research seminar. We have that in this room 3 times a month, first, second, third Thursday. And we focus on a different topic. Like I think this month is more on ethics. Last month we did clinicaltrials.gov. Every session was something different about ct.gov. This month I think we did consent. We did SAEs last week. This week we're going to do a journal review or an article review about ethics, and then next week is about regulatory. But every month is sort of a different theme. So we're trying to get to the more in-depth down here. So again, we've done a very bad job of marketing. We've been building these programs over the past few years, and now we need to fine-tune. And again, the intent of all of this is to address the competencies, to make sure we touch on those completely. So, as you can see, I didn't finish my slides. So, anyhow, please contact me at any time. Darty works with me. I just didn't put that in there. If anybody has any questions, I'd be glad to take them. Thank you all very much. And if anybody wants a book, we have some. If you want one of these, I can put them out. Otherwise, you certainly can find them on the team has them back here.